Thank you, Dr. Shubhangi ma'am, for giving me an opportunity and the scientific committee for making me a part of this interesting instruction course. Actually, the time is 12 minutes. I mean, by he's not able to change that. उसको 12 मिनट कर दो. Talk is 12 minutes. So I'll be presenting on Brown syndrome. I would like to. I'm sorry because I have to go to another session. So we'll start with the case of a girl, an 8-year-old girl. Her parents complained that there was some abnormal eye movement. They were not very sure what it is, but you can see there is some limitation in elevation in adduction in the right eye, and she has divergence excess in the up gaze. And in the right eye, it is quite obvious that she has got limitation in elevation in adduction. So usually in these cases, you have to look down also, so that to see for any ipsilateral overaction of the ipsilateral antagonist. So because there wasn't, it definitely was a kind of a restrictive strabismus. Sharing another case,
देखना है उंगली की तरफ. अच्छा, इस तरफ देखिए उंगली की तरफ.
the above movement, she had you can see that she has got a downshoot on attempted adduction in the left eye.
इधर
And
देखिए
definitely
ऊपर.
there was
हाँ,
limitation in
ऊपर देखिए छत की तरफ, गर्दन नहीं हिलाने से.
is the way we saw it
अभी
was
मेरी ये वाली उंगली की तरफ
and
देखिए.
she
इधर
had
देखिए नीचे.
downshoot in the right eye also, similar feature in the right eye with limitation in elevation in adduction. So
इधर देखिए ऊपर.
additional
बहुत.
feature was she had a downshoot. So there was limitation in elevation in adduction with mild to no limitation in elevation in upgaze, whereas in abduction it was normal. Some patient, like the second case, had a downshoot. Your patient might present with a V or Y pattern. In addition to that, the patient, some patients, if they develop a hypotropia, they will have a chin up posture. Palpebral fissure changes the way we get in Duane's are less likely to happen in Brown's. So coming to Brown syndrome, the basic, it was originally called superior oblique sheath syndrome because it was believed that the sheath, I mean, the functional origin of superior oblique is from the trochlea. So the sheath beyond the trochlea was supposed to be affected, but Dr. Harold Brown found that it was the entire muscle was tethered, so entire tendon beyond the trochlea was tethered. It's after him that this syndrome is named. It's more common in females, and around 90% are unilateral, but both the cases which I showed were bilateral actually. The most common differential diagnosis is a paretic variety, that is inferior oblique paresis, because the limitation in elevation can happen in inferior oblique paresis also. The basic difference between a restrictive and a paretic strabismus on ocular motility is the overaction of the ipsilateral antagonist, which doesn't happen in Browns, but in inferior oblique paresis you will have a superior oblique overaction leading to a pattern. And of course, force reduction test will help you to differentiate. Around literature has found that around 16% cases of Browns might have I mean improvement or remission with time. So how to do a force reduction test for oblique? Actually, we need to make the tendon taut by pressing the globe down, so that the tendon becomes taut, and look for excyclotorsion and encyclotorsion. In Browns, the excyclotorsion part will be difficult to be done because the superior oblique doesn't allow that to happen. Brown syndrome can present with horizontal squint like esotropia. If there is no, a chin up or any abnormal head posture, Brown syndrome may not be tackled at this stage. Or sometimes with exotropia, like in this girl, she had a bilateral Browns in addition to exotropia and also abnormal head posture. You can attempt both the correction of the horizontal as well as the Brown syndrome as well in these cases. Sometimes Brown syndrome might have, in addition to the downshoot, there might be elevation limitation in elevation in upgaze, but it's definitely more marked in adduction, whereas the abduction part is normal. So this helps in differentiating it from the monocular elevation deficit, where all the upgaze positions are limited. So the basic management plan for this condition, any patient with a limitation of elevation in adduction, do a force reduction test to find out whether it is a restrictive variety or a paretic variety. If it is negative, we think in terms of inferior oblique paresis. If it is positive, either it can be Brown's, rarely it can be orbital floor fracture or a thyroid related orbitopathy also. Coming to Brown syndrome, which is congenital, acquired, and iatrogenic. Iatrogenic is because of excessive tuck in congenital superior oblique palsy. So in these cases, we need to explore the tuck. Acquired can be traumatic or it can be inflammatory. If it is traumatic, we do the surgical exploration. If it is inflammatory, by orbital inflammations, either treated with steroids or a non-steroidal agent also. Congenital type is the most common. It can be with a normal head posture or an abnormal head posture. If there is no abnormal head posture, better not to touch these muscles, touch these cases. Abnormal head posture which is stable for a prolonged period of time can be considered for surgery, and these are the two commonly done surgeries in in Brown syndrome. The problem with Brown syndrome is that it is a restrictive squint. So I mean, every restrictive squint is a variety of its own. So you have to individualize the case. Also, it is a superior oblique, which in olden days was never touched by or not touched by many of the strabismologists. The problem with superior oblique is that it helps. It usually helps in down gaze, which is most functional part of our gazes. So if you try to weaken it, in case of Brown syndrome, it might give a picture of a superior oblique paresis. And if you like to strengthen it by doing a tuck in a case of superior oblique palsy, we might have a Brown syndrome. So you need to explain these, counseling part to the patient beforehand. Except for the name oblique, there is no similarity as far as surgical point is concerned between superior oblique and inferior oblique. So if you are contemplating a surgery for Brown syndrome, try to avoid it as much as possible. If there is no abnormal head posture, consider only if it is abnormal head posture without any sign of remission. Set the realistic goal to the patient that it is mainly to correct the head posture, and actually this part applies to all squint surgeries for restrictive strabismus, that head posture is what we need to correct, and ocular motility might improve but not completely correct itself. There are chances of diplopia, especially in down gazes, which might need prisms later on. And final decision making, especially, is done after doing the force reduction test, which is done on table. Most of them are children, so doing FDT in OPD might be a difficult proposition. So the weakening procedures are the tenotomy. Still, I think it's the most commonly done surgery because of the ease of doing it. But a more titrated procedure like silicone band or a non-absorbable suture can be used. This was a patient who had exotropia with Brown syndrome. She had undergone a congenital cataract surgery early in childhood. So this was a right eye. I'm showing a video of a tenotomy. Before doing the surgery, we do a force reduction test to see how much amount of tight the superior oblique is, and then we hook the superior rectus muscle, stabilize it either with a Jameson hook or a Green's hook, and then we need a proper exposure. And hooking the superior oblique is a bit tough because it is tight, and superior oblique lies posterior to the superior rectus muscle. So we might have to do a posterior tenotomy with proper exposure, either using Demars retractor or Barbie's retractor. And then we see the superior oblique fibers, which are glistening white fibers under the superior rectus, and the hooking part is a bit tough. So ensure that you have hooked all the muscle fibers, because otherwise the effect will not be there. Usually temporally the tendon is small. It is nasally that it is more fanned out, and once it is hooked, then it's up to you what we have to do. So there are surgeons who do Z tenotomy. Some surgeons do only the cutting of the anterior fibers of the superior oblique. But when you have to do a free tenotomy, you can simply cut the muscle. The important part is after cutting the muscle, do a force reduction test to see how much amount of effect this procedure has actually achieved. So I would like to thank Dr. Shubhangi ma'am for this particular video. I'll share this video later on. Actually, there is some technical problem. So this is a video of tendon expander. So we go to the next slide. Superior oblique tendon, what literature says is that superior oblique tendon sheath syndrome is not the name anymore. Though clinically we suspect Brown syndrome, many clinicians feel that FDT may not be necessary to diagnose the condition, only when we were contemplating a surgery. Spontaneous resolution can occur, and though according to Kenneth Wright, superior oblique tenotomy is the preferred procedure, tendon expander might provide more titrated results in these cases. So Brown syndrome is an important restrictive strabismus. Congenital variety is most common. Majority of the cases do not need treatment, Treatment should be considered only if there is no further improvement with time and patient has an abnormal head posture. And the more commonly done surgery even today is superior oblique tenotomy. So always set realistic goals to the patient whenever we are advising or planning a surgery. I'll just share the video of uh, the tendon expander. Yeah. So we go nasally, superior nasal in these cases, and we use 50 Mercilin or 50 Ethibond on both the sides of the superior oblique. You can before actually cutting the muscle, ensure that when you are cutting, the inferior sheath of the superior oblique is not cut, so that whenever you are passing the 240 band, it does not touch the sclera. Otherwise, it will behave more like a belt buckle and less like a silicone tendon expander. So also chances of extrusion are less whenever we are, whenever the sheath is preserved. So this is more titrated and more predictable result compared to a free tenotomy of the superior oblique. Thank you. Thanks.
Thank you, Rishi, for a wonderful talk. I just want to, do you want to ask anything, Suma? Yeah. Hypotrophy. Yes, palsy. Troublesome
Troublesome.
Browns.
Yeah.
Hmm. Yes.
Actually,
And even about the tenotomy, what you said is anterior fibers. If you just cut the anterior fibers, then it will just correct the intorting effect, because tendon which is on temporal side, anterior 1/3 is responsible for intorsion and posterior 2/3 for depression. So in order to get that effect, you have to accordingly recess that particular part. And one thing is, after the surgery for Browns, never expect an improvement in elevation in adduction. That may not happen. We are just interested in correcting the primary position hypotropia.